Thank you all very much for coming. It's a great pleasure to welcome our two speakers this evening, Andrew Latham and Somogy Varga. Somogy is Professor of Philosophy at Aarhus University. With a PhD from Frankfurt, he's published 3 books, I think I'm right in saying, although the count is quite high, easy to lose track. Authenticity as an Ethical Ideal, Naturalism, Interpretation and Mental Disorder, and most recently Scaffolded Minds, and he has a 4th on its way next year with CUP, Science, Medicine and the Aims of Inquiry. And Andrew Latham is a postdoctoral research fellow also at Aarhus, having previously been Anderson Junior Research Fellow in the Department of Philosophy and postdoctoral research fellow in the Centre for Time at the University of Sydney. Their topic tonight is Health and Disease, Experimental Philosophy of Medicine. Over to you.
Thank you very much for this wonderful introduction and for inviting us to talk here and giving us this opportunity to present some of our recent work on health and disease in this forum. The work we are about to share is quite new, so we are looking forward to receiving feedback and comments to improve our work in the future. So let's start with this basic question in the philosophy of medicine. What are health and disease? What I'm going to do here is to give you a very brief introduction into 2 main issues in this debate and 5 positions. So why do we care about these questions? What are health and disease? Well, there are some important consequences for scientific research, for clinical decision-making, for public health measures, and for healthcare resource distribution. So let's just take a couple of examples. So if a condition is considered a disease, then that changes a couple of things about how we view people with these conditions. So it changes our perception and response towards these individuals with that condition. For example, we might see them as deserving medical care or as deserving to be excused from certain behaviors, maybe from their roles, certain jobs, if those behaviors are linked to their condition. But it also changes whether that condition will be targeted by public health policy, whether that condition will be covered by health insurance, and whether that condition is going to be the focus of future research. So it changes quite a number of things. These are really important questions, we think. So it's maybe not very surprising that these questions are and have been the subject of extensive philosophical research and debates, sometimes also very, very heated debates. So the debates surrounding the concepts of health and disease can be distilled, so we think, into 2 kind of primary issues. We call these 2 issues the evaluative issue and the relational issue. So what is the evaluative issue about? The question is whether health and disease are value-laden, evaluative concepts, or are they value-free descriptive concepts? I'll say a little bit more about what that means. The relational issue is maybe easier to grasp. It's just how health and disease are related to each other. Whether health is something like the absence of disease, or is health something more than that, some presence of a capacity, of something like robustness or resilience or something else. Okay? So those 2 main issues. Now let's delve a little bit deeper into those issues. So the evaluative issue, remember this was the issue whether health and disease are value-laden or value-free. There are 3 positions. Unfortunately, these are 3 isms, but bear with me. Naturalism is kind of a dominant position in the literature. And the main idea here is that health and disease are value-free concepts. So what does it mean? This means that it is biological or psychological facts about abnormal functioning that make some condition or state, let's call it condition X, a disease. So classification as a disease is independent on the value or disvalue that we attach to this condition. Right? It's all about psychological or biological facts about the condition. Now this is naturalism. Normativism is usually described as the exact opposite view. It's the view that health and disease are value-laden concepts. They are evaluative concepts. And what does that mean? Well, it means that it is because condition X is harmful or disvaluable that it becomes classified as a disease. So it is the harm and the disvalue that makes the condition a disease rather than biological or psychological facts about this condition. Now these are the two kind of main positions. Hybridism tries to navigate both positions. So on hybridism, for something to be a disease, two requirements have to be fulfilled. Each of these requirements comes from naturalism and from normativism. So on hybridism, something is a disease if it involves some abnormal functioning that we can detect by appealing to empirical facts. This is what hybridism inherits from naturalism. This is the kind of a supposedly value-free component. But it also has to be the case that the abnormal functioning that we kind of associate with this condition is somehow disvalued and harmful. This is the part that hybridism takes from normativism. So hopefully these three main positions are somewhat clear. Now we move on to the second issue, namely the relational issue. And remember, this was the issue how health and disease are related to each other. Here there are only two isms. Negativism, just the idea that health is the absence of disease. So this means if somebody has condition X and X is a disease, then this person is not healthy. The competing position is, let's call this positivism, is that health is the presence of some positive state or ability. Again, we could say this is something like robustness, resilience, or again, something else. But here, something else is possible. So, because if someone has X, condition X, and condition X is a disease, then this person might still turn out to be healthy. Right? So it's a different issue. And positivism is, by the way, the concept of health that WHO uses and people in public health usually operate with. All right. So this is how it looks. This is how the five isms look. You see the evaluative issue on top, whether health and disease are value-laden or value-free concepts, and the relational issue below, whether how health and disease are related. Good. Now let me say a little bit about the current debate and the methods which philosophers use to propel the discussion. Philosophers have traditionally explored these matters through using conceptual analyses. And the idea was just to gain insights on what falls under the label health and disease by examining intuitive judgments about various cases. This could be cases from medical books, but this could also be imaginary cases. So the idea is here with this method that intuitive judgments offer insights into concepts of health and disease, into the actual properties or relations that these concepts pick out. Now, all that said, in recent years, an increasing number of people in these debates argue that this method has led us to a deadlock. So the debate has become stalled. As Peter Schwartz puts it, it has led us to a dull thud of conflicting intuitions. So we haven't made progress for a while because we simply have differing intuitions on certain cases. So natural question is, how could we advance the debate here? Well, some philosophers have recently advocated the use of alternative methods, such as empirical approaches from experimental philosophy. And it's important to note that they're not suggesting that we replace conceptual analysis entirely, but we use empirical methods from experimental philosophy to supplement conceptual analyses. Right. So let me say something very briefly about what experimental philosophy is. Typically, experimental philosophy empirically examines people's judgments in response to certain short stories, which are usually referred to as vignettes. And these vignettes describe kind of carefully crafted, designed scenarios, not unlike those we use in thought experiments in philosophy, that are presented to participants who are then prompted, who are then asked to respond to certain questions. So when these vignettes are designed, they typically consist of two types of factors. There are controlled factors, which remain constant across vignettes. And there are experimental factors that are manipulated across the vignettes. Once we manipulate these, then they allow for the assessment of their impact on dependent variables. So we can then compare people's responses between different vignettes and kind of gather evidence about the content of people's concepts through analyzing the patterns of judgments. All right, so let's take an example. This is a very simple example of how this might be done. This is actually the first study we did on health and disease. And this is a vignette exploring the relational issue. And we had two groups of participants, medical students that I happen to teach, and a sample of from the general population. So, and here's the vignette. There are two protagonists here, Mila and Luca. And I'm just going to read it for you. Mila lives an active lifestyle and at her yearly checkup tells her physician that she is feeling great. The physician informs Mila that while all her tests results are normal, so blood pressure, cholesterol, BMI, and so on, she has tested positive for celiac disease. Mila would never have known that she had celiac disease had the physician not performed the test. That's because Mila never eats gluten and lives in a gluten-free community. All right, now enter Luca. So Luca lives a sedentary lifestyle and at her yearly checkup tells her physician that she's feeling okay. The physician informs Luca that both that she's disease-free and that all her test results are normal. However, the physician also tells Luca that while her blood pressure, cholesterol, triglycerides, BMI, and so on are all within the normal range, they are all very close to being classed as abnormal. All right, so that's the vignette. Now we had a couple of comprehension questions. Does Luca have a disease? And the probe questions were, in this scenario, is Mila healthy? Is Luca healthy? And then the comparison question, between these two scenarios, who do you think is healthier, Mila or Luca? So here is how participants responded. You see the first question, in this scenario, Mila is healthy, and remember, Mila was the person with celiac disease. The overwhelming majority of people responded yes, she's healthy, Mila is healthy. In this scenario, Luca is healthy, this was the person without a disease. 82%, so so just as many as in the first case, respond yes. And in the third question, so between these two scenarios, who is healthier? 76% of our participants respond that Mila is healthier. And remember, Mila was the person with celiac disease. So we think these results are interesting and have interesting implications for the relational issue. This is because if negativism is correct, then people should judge in a certain way, right? They should judge that Mila is unhealthy. Why? Well, because she has a disease after all. They should judge that Luca is healthy. Why? Well, because she doesn't have a disease. And they should also judge that Luca is healthier than Mila. However, that's not what we find. In fact, our findings are consistent with positivism. So people agree that Mila is healthy, even though she has a disease. They agree that Luca is healthy, and they judge that Mila, so the person with the disease, is actually healthier than Luca, the person without the disease. So the implications, we think, are relatively straightforward. This means that we need to somehow rein in or restrict negativism. Maybe there's a weaker version of negativism that could be rendered consistent with our findings. But there's also a second implication, which is a more general one, is that, well, it's worth dealing with health separately, because an analysis of disease will not give us a comprehensive picture of what health is. All right, so just a couple of comments on some characteristic features of our approach, and then we'll get to our main results. So we investigate people's concepts of health and disease, already said that, but we do this through investigating what factors influence their judgments about whether to categorize a condition as health or disease. And then we also look at how these judgments may vary across different demographic groups. But we do this with those issues in mind that I mentioned in the very beginning, the evaluative issue and the relational issue. So of course, many researchers from other areas of investigation have studied people's concepts of health and disease. Researchers from medical sociology, anthropology, health psychology have done so. But we find that our approach is different. What is typically done in something like medical sociology is that researchers identify a number of themes in people's conceptualization of health and disease, and they look for cross-cultural differences. What is typically done in these studies is that they typically use semi-structured interviews and ask people to describe what health is for them, ask them to describe somebody they know who's really healthy, and questions like that. So many of these studies ask participants to define or to articulate or elaborate on their concepts. We do something different. We ask them to deploy their concepts by making judgments about various scenarios. So by examining their judgments, we're able to gather evidence about the content of their concepts, even if that content is largely opaque to them, even if that content is largely implicit. So we don't require them to define or to articulate their concepts. All right, so but you could say, well, so what do we really hope to gain by investigating people's judgments? Well, I think knowledge about this type of knowledge about people's concepts can inform the philosophical debates, but it can also really be helpful in clinical and public health contexts. So let's take the philosophical debates first. Philosophers engaging in conceptual analyses of health and disease, they make appeals to these types of intuitive shared judgments about certain cases. Let me briefly cite a well-known figure in the debate, Jerome Wakefield. He says, and I quote, "In a conceptual analysis, proposed accounts of a concept are tested against relatively uncontroversial and widely shared judgments about what does and does not fall under the concept. To the degree that the analysis explains these uncontroversial judgments, it is considered confirmed, and a sufficiently conferred analysis may then be used as a guide in thinking about more controversial cases." End of quote. So clearly there's this emphasis on widely shared judgments. But as we know from empirical psychology, there might be a disconnect between what philosophers think that our widely shared judgments are about certain cases and what ordinary people actually judge about those cases. So, supplementing traditional conceptual analyses with this type of empirical information about widely shared judgments can propel the debates, or so we think. But this is not all. I think so we think that by investigating people's judgments, we can also inform clinical and public health contexts. We're going to keep this very brief. A solid grasp of people's concepts are important for public health and clinical medicine. In public health, they're important for measuring health, self-reported health, and for designing effective interventions. Why? Well, because the lack of understanding these concepts could lead to incomplete or inaccurate assessments of health, which could then ultimately limit the effectiveness of certain interventions and policies. In clinical medicine, knowledge about people's concepts would help make sure that effective communication occurs with patients. For example, medical doctors might operate with slightly different concepts of health and disease compared to lay people. That could lead to a misalignment of goals and intentions. All right, so after these introductions, let's get to our overarching findings, which Andrew is going to present for us.
Sweet. All right, so what I want to do is basically present, rather than kind of run through result after result after result, what I want to do is basically kind of give you a feel for what are kind of some robust overarching results that kind of cut across all the various kinds of studies we've run so far. And I'm going to do this in a few steps. So I'm going to begin by basically presenting some different cases that we've used, at least an exemplar, and basically run through how those various kinds of exemplars are kind of manipulated to see how various kinds of factors might influence people's judgments to various health and disease cases. After that, I'll take you through basically some exemplars of some of the kinds of things that we're interested in asking participants about. We weren't just interested in asking about health and disease, but other kinds of questions as well, such as, is this particular condition, does it fall under the scope of medicine? Or is it the kind of thing that medicine ought to intervene on, and so on. And then after that, I'll take you through a few kind of the robust findings that cut across all the kind of vignettes, all the kinds of scenarios we've run. And then I'll finish off by thanking some collaborators that we've worked with. So let's do the easy slide, which is a story. So I'll read it out to you, so relax for the moment, and then I'll take you through what we did with it. So Alex, a 45-year-old CEO, heads a company specializing in the production of landmines. The company has received criticism from humanitarian groups for perpetrating suffering and ignoring the devastating consequences that landmines have on civilians, including children, who inadvertently come into contact with them. Alex does not care about such ethical issues. He is deeply committed to the company's growth and success, and he works hard to ensure its continued expansion, even if his job is very stressful. Alex is aware that work stress can be detrimental to his health, but he prioritizes the company's success over a healthy lifestyle. He does not work out, eat balanced meals, or get sufficient sleep. Lately, Alex has been experiencing trouble with some regular activities. He developed a condition characterized by the consistent inability to maintain attention due to experiences of disruptive anxiety. After multiple medical consultations and tests, his doctor explained to him that this condition is the result of prolonged work-related stress, which has elevated his cortisol levels. Alex strongly dislikes his condition and considers it to be harmful. In fact, he sees it as posing considerable difficulties for him as things other than the growth of his company matter to him. So you can imagine getting a scenario like this and then just being asked some various kinds of judgments. Is Alex a healthy individual? Is Alex's condition here one that might be characteristic of a sickness, a disease, or a disorder? Is Alex's condition the one that something that medicine, does it fall under the scope of medicine, or is it something that medicine has a right to kind of intervene on, and so on? But in addition to that, you can also ask, well, what happens if we kind of switch out some of the various kinds of descriptions there of this particular case, and by switching the description up, does it actually influence your judgments in any kind of way? So at the top, you can see, for instance, at least for this particular vignette, the kinds of features that we're actually interested in looking at. So for instance, Alex here is being described as having a very kind of high-level kind of bad character, but what happens if we change the description to be someone who works for humanitarian purposes? In this particular case, what if he was committed to kind of removing landmines and making no profit in doing so? Would this affect your health or disease or sickness or disorder judgments? Well, this is not something I'll go into later. As a matter of fact, it does, or at least that's what we've found. People tend to judge, for instance, that people of good character are healthier than people of bad character. And what's more, the condition here, namely the anxiety, is judged much more likely to be a disease or a disorder if the person has a bad character than if they have a good. And in addition, you can imagine changing up, what if we changed up his lifestyle? What if we changed up the condition itself? What if, apart from anxiety, it was a physical condition or a physical ailment? And finally, what happens about the patient themselves? Does what the patient thinks about the condition actually, in fact, influence what you think about the condition as well? And so this is just one combination of these various kinds of factors, but you can imagine all the various kinds of recombinations of this. And what we're interested in doing is basically, with the analyses, is seeing how each of these factors and their various interactions influence people's judgments. For the purposes of time, I'll skip the next case. This is just a case involving ADHD and the person not minding the fact they have ADHD. And we compared this again with a physical case, but also where they do mind the fact they have the condition as well, and whether or not that actually influences their judgments. So, as I alluded to earlier, we weren't just interested in people's health and disease judgments, we're also interested in other broad categories of judgments as well. In particular, this medicine medicalization kind of category, we're interested in, look, what is the extent to which the condition we described a medical problem? Now, why are we interested in this? Well, it's quite likely that these questions about health, disease, disorder, and sickness come apart from what falls under the scope of medicine. That is, it's possible that people might judge that a certain condition might be a sickness or a disease or a disorder, but nevertheless not think it falls under the scope of medicine. And likewise, the further kind of question here is, even if it falls under the scope of medicine, what are the factors that influence whether or not people think medicine has a right to intervene in those particular kinds of cases? And the final one here is people's attitudes towards the kind of condition being described. Now, this first one here about dysfunction, of course, is not really an attitude at all, but that's there to kind of preempt a result that's going to come later. The key one here is what people think regarding whether or not the condition being described is in fact undesirable or not. And I'll come back to that because it's an important finding later on. So what are the four kind of overarching findings I want to discuss with you as these four here? Firstly, people are actually very, very resistant to make disease, disorder, sickness judgments, and are really, really resistant to actually judge that people are unhealthy. I'll show some examples of this shortly, but that's just the first one I want to go through. Second is something that is kind of absent from the literature, but that is actually the source of the condition actually affects people's disease, disorder, and sickness judgments, as well as their medicalization judgments. Which way that goes, I'll say more about shortly as well. Thirdly is that, quite apart from actually the factors you manipulate in a particular case, if you don't take for granted whether the people are actually reading the factors as you would expect, or hope they do, but actually get them to actually evaluate whether this particular condition describes a dysfunction or not, once you take that into account, it actually becomes, at least in this case, perceived dysfunction is just the biggest predictor of both health and disease judgments. And finally, the one we're kind of working on currently, which is that whatever this perceived dysfunction is tracking with people is not what people, at least in this literature, think of as being dysfunction. In fact, whatever the kind of lay notion of dysfunction looks much, much more like a certain kind of evaluative judgment than not. So let me start with the first one, though. People being resistant to make these kind of disease, sickness judgments on the one hand, and judging that someone is unhealthy on the other. So I apologize for the world's worst figure, but I'll take you through it, or at least the key message is really simple once I kind of walk you through it. So the scale on the left here is basically, at least when we're doing this particular study that I'm giving an example of, is just level of agreement that someone is healthy. And along the bottom here are all the various kinds of combinations, at least with respect to a certain kind of physical ailment in this particular case. And in some sense, it doesn't really matter what these different combinations are, because no matter what combination you give, people are near or at ceiling in most of the cases when it comes to judging whether someone is healthy. It doesn't matter if you describe a condition, for instance, where essentially they're blind, where they hate their condition, the community hates their condition, and they wish it would go away. You get people coming down, of course, but people are very, very reluctant to judge that person is unhealthy or necessarily unhealthy. So even when you stack, as it were, all the factors in favor of an account that you would predict would judge that this particular individual is unhealthy, people are nevertheless resistant to actually agree that such a person is unhealthy. And in fact, will tend to agree that they are healthy after all. And it goes the other way when you talk about disease judgments. Again, the case I just described, a person with a dysfunctional visual system, which they dislike about themselves, which their friends and family dislike about them. Again, stacking all the kinds of factors that the literature would have predicted as kind of determining that people would judge that this person has a disease or a sickness or a disorder, people tend to actually be very, very reluctant to judge that they in fact have a disease, a sickness, or a disorder. And this goes for both physical dysfunctions or physical diseases, but also mental health cases as well. So there's no distinction here, as it were, between whether we're describing physical conditions or mental conditions. Of course, there's a little bit of more variability in this case, but again, most people are at floor or towards floor when it comes to disease judgments. Now, what are some implications of this? Well, recall the evaluative issue, which is whether or not health and disease are value-free or value-laden kinds of concepts. One thing this kind of resistance maybe pushes you towards, at least, is the thought that they're obviously not purely descriptive concepts. In some sense, there are plenty of conditions that we seem to set up for people, which would seem to meet the description of many of these kinds of at least descriptive accounts of what it would take to have a disease or what it would take to be unhealthy. But most people are very, very reluctant, as it were, to agree that such a person has a disease or a sickness or a disorder or is in fact unhealthy. There's something else, which at least is not apparent here, which is missing from the kinds of scenarios that we present to people that will tip them over the edge, as it were. Now, of course, it's possible that the descriptions we've kind of come up with just don't meet the description, the relevant descriptions of what it means to be unhealthy, what it means to have a disease or a disorder. But we've used some pretty extreme cases. So, for instance, we've used a case, for instance, of a fictional mental disorder where a person is just entirely incapable of actually deliberating. and where their inability to deliberate, and so they just go around kind of making these kind of intuitive kind of point from the hip kinds of judgments, results in them causing great harm to themselves and their family. And they dislike this fact, and everyone dislikes it. Even in these kinds of cases, you see the same sort of resistance. So it's not, even though we might be missing something, it's not clear what is necessarily missing from the kinds of descriptions we've put up to people. So if you have any suggestions, I would love to hear them as well. What about the second overarching finding? So this one was slightly novel, but was something that we're interested in testing out, which was maybe the condition, the source of a condition matters. So maybe it's not the kind of the nature of the condition, that is the difference between having a kind of a physical ailment on the one hand or a mental ailment on the other, but maybe what matters is the source of the condition, and that's going to push people's judgments in various kinds of ways. So this is the difference between having a condition that's the result of some kind of biological agent versus having a condition that's a result of various kinds of social phenomena. And as a matter of fact, it does. So what we found is that even though there's a slight resistance, when you describe a condition as having a biological source, that has a significant effect on people's disease, disorder, or sickness judgments. Namely, they are much more liable to agree that such a person has a sickness or a disorder. However, if you describe it having a social cause, you don't see that effect at all. The other interesting thing here, though, is that it only has an effect on people's disease and disorder judgments. It has no effect on their health judgments. So describing someone as having a condition that's a result of a biological agent causes people to be more likely to agree that such a person has a disease or a disorder, but it has no effect on their accompanying health judgments for that person as well. Now, what's one implication of this? Well, recall the relational issue again. And the relational issue is, what's the relationship between our kind of disease concept on the one hand and our health concept on the other? And recall the position of negativism about disease, namely that health on this particular account just means having the absence of having a disease. Well, there are various kinds of factors that can influence or push one set of judgments, and so meet the description of, say, having a disease, but has no consequent influence on the other, that is, whether a person is healthy or not, then these two things seem to pull apart in a way that negativism wouldn't predict. Of course, the other interesting thing about these particular findings is that it's actually absent from theorizing about our concept of disease, that condition source should matter. Now, of course, this is not to suggest that although it was suggested earlier that, look, experimental philosophy can kind of play a role in maybe a certain kind of conceptual analysis. It doesn't mean, for instance, that just because we find that condition source has an effect on these kinds of judgments, that we should automatically think that it ought to be a part of our concept of disease in this case. In fact, there are probably good reasons, for instance, for not wanting to make a distinction between these two. If it turns out, for instance, that the very same phenotype is much more likely to be judged to be a disease just in virtue of having a biological cause as opposed to a social cause, even though the consequences of the patient are the same, that's probably not something you want to be a part of the concept. But nevertheless, even though it's not something we might want to be part of a concept we might want to engineer, it's still true of our current practices that this seems to influence at least many of our judgments now in that particular way. So it might matter, for instance, how you go about describing conditions to people and the kind of source that it might have. Now, this is probably the biggest finding, and this came as a result of, well, look, we were happy describing dysfunctions for people, and the descriptions of the dysfunctions that we're coming up with for people were being motivated by, as it were, the kind of theoretical literature. Now, maybe it's probably not going to be a surprise to some people, but sometimes the theoretical literature can be slightly detached from, as a matter of fact, what most people think would count as a dysfunction or not. And so even though we were coming up with these descriptions that were motivated by what would count as a dysfunction given the kind of theoretical literature, it's really up for grabs whether the people we're actually getting to respond to these kinds of cases actually do think they're dysfunctions or not. And what we found was that once you actually ask people, like, look, what's the level of dysfunction in this particular kind of case? Once you actually take that into account and feed it back into the model, then it's actually the strongest predictor of both people's health and disease judgments. That is, there seems to be a straightforward kind of linear relationship between how dysfunctional people think a particular case is. Again, irrespective of whether it's a physical case or a mental case, and the resulting health and disease judgments. Now, although it's the strongest predictor, there's a huge amount of variability in these kinds of results, and so I'll put up the graphs and then we'll kind of come through it because there's a further thing that's even stronger, or it seems to be more important than perceived dysfunction. So, again, horrible graphs. I must apologize. In this particular case, there's a mental health condition, and as you can see, there's a huge variability in people's judgments. So I'm not saying, for instance, that this is the kind of, even though it's the strongest predictor, it still leaves a lot of variance up for grabs in what's actually motivating or pushing people's judgments in various kinds of ways. But generally speaking, once you take into account what people's perceived level of dysfunction is for a particular kind of condition, it tracks reasonably with how healthy and whether or not the person has a disease or a disordered condition. So in this particular case, you see basically the relationship between having a dysfunction and health judgments, and it tracks in the opposite direction when it comes to disease or disorder judgments. That is, as the perceived level of dysfunction increases, so too does the level of agreement that the person has a disease, a sickness, or a disorder. I'll come back to this in a second because there's something much more interesting going on in this particular result. This is more of a kind of something hinting that we're missing something from the original descriptions, and I'll come to what that might be in a second. But what was interesting about this is some of the earliest work on people's concept of health and disease, this was actually consistent with that work. The earliest work on this kind of question actually showed that the only thing which predicted or influenced people's health and disease judgments was in fact dysfunction. What the patient thought about the condition had no effect. What the group thought about the condition had no effect. It only seemed to be dysfunction. And so this result, or this at least seeming tracking association between perceived level of dysfunction and health and disease, is actually consistent with at least the earliest work on this by Edward Macharet. And of course, if we read dysfunction or perceived level of dysfunction here in the way that at least many people in the literature would like us to read it, then this would at least seem to suggest, or at least be consistent with people having a proto-naturalist concept. That is, the more certain they are that there's a dysfunction present here, the more likely this person has a disease or a disorder, and vice versa in the case of health. But the problem here, of course, is that it really leaves open how people are actually understanding dysfunction. I mean, it'd be really, really nice if people were reading it like they had either a kind of a descriptive notion of function and or they had a kind of objective notion of function, and they were just kind of reading off kind of, good philosophy of biology about what those things are and applying these cases. Wishful thinking. Of course, that's not likely the case. But then the question becomes, well, what are they actually tracking with that? Or what are they actually tracking with this kind of dysfunction judgment? And this is the fourth finding, and it's probably the biggest one, and it's the one that I've literally been working on up until end of last week. And that is, funnily enough, the thing that people see, what seems to be being tracked with perceived levels of dysfunction is just undesirability. What perceived level of dysfunction is tracking with people is just how undesirable they find a particular condition. So basically what's happening is that when we presented these cases in the past, and when we see, for instance, people are really not wanting to make a disease judgment in these particular cases, although they're not want to make a healthy judgment in these particular kind of cases, what seems to be going on is that we see the kind of association between dysfunction and health and disease judgments, because although there is a slight association between them, people are finding the conditions we described slightly undesirable, but they're not sufficiently undesirable to actually trip people into actually judging that this person is unhealthy or judging that this person has a disease or a disorder. So undesirability here is really seemingly what people are reading into when they read dysfunction. Yes, having been colorblind is undesirable, and so this consequently results people in making slightly lower health judgments or slightly higher disorder judgments. But of course, it's not sufficiently undesirable for it to be the kind of condition that's classed as kind of a sickness or disease or disorder. Whereas for other kinds of cases, even if they're seemingly mild, if you associate them with sufficiently bad outcomes for the person or the community or their family, then you do start to see the sickness or disease or the disorder judgment come into play, as well as the unhealthy judgment. In these particular cases, it seems that when you actually push the condition to make it much, much more undesirable, then you start to see the kind of findings we might have been expecting. It also makes sense of an earlier finding I just described about why is it that seemingly bad character might actually have an effect on the degree to which people judge anxiety to be a disorder. Well, insofar as just, again, evaluating someone as having a bad character is just another kind of thing that feeds into this kind of undesirability judgment about a particular case, then it might naturally just feed into undesirability regarding the condition that they in fact possess as well. So that's kind of where we're at the moment, where we kind of went full circle. So going from the kind of theoretical literature, we realized that there were some things kind of missing. And what we found was that really underlying much of the kind of work or much of the effects that people in the theoretical literature are particularly important is really a kind of evaluative judgment about how undesirable this particular condition that we think is. Now, of course, I don't think it's straightforwardly just undesirability, mind you. Of course, there has to be some kind of constraints here. After all, we don't think that every undesirable condition there is counts as an instance of a disease or counts against being healthy or not. And so there is something missing from this picture. Condition source hints at something that might put some constraints on it, but still an open question about why is it that only certain undesirable conditions are ones that get to count as disease or disorder, and what are those things that put boundaries around, or put a circle around these particular conditions, which we don't know at this time. So just quickly to round off, a couple of collaborators, Edward Masharet from University of Pittsburgh and Jacob Steginga from Cambridge University. These are the papers that have been completed. If you want any of the materials or any of the data or want to give any feedback on those papers, just get in contact and we'll be more than happy to share them with you. But thank you very much.
Hiya. I just had a question kind of thinking about undesirability, whether perceptions of others' health was affected at all on perception of your own health, so whether people who were considered themselves unhealthy or were, had a lot of disease, perceived others as more or less healthy, as the case may be.
Yeah, thank you very much. That's a great question. That's not something we looked into, but it's something that we definitely thought about for us also for the future. So this goes on the list. Thank you.
Just wondering where it fits in with all this you're talking about. When a person goes to the GP and says that they're depressed, they're then given a little list of little questionnaire, which apparently was devised by Pfizer in the first place, and they answer these questions, and as a result of whatever they've come up with, if the score is high enough, they're immediately given antidepressants, which seems like, with everything you said there, seems like that is a judgment based purely on the patient's conception of what it is they're going through, which almost seems to go against some of the data that you found, that you had in your graphs. Do you have any feelings on how the way mental health is immediately medicalized like that fits in with the findings that you've got? I'm sorry if I'm not asking that correctly.
No, I might take a first stab at that. So I think it connects up nicely with the point which is made here, which is that in some sense the people that we've been surveying they're not a clinical population, and in some sense we might make certain kinds of assumptions about the kinds of judgments they might make about their own health and their own disease or their own health status. And so I would expect that if, for instance, we had a look at a population, for instance, that were I've got the name of the inventory, but were kind of tending towards kind of mild depressive or medium depressive episodes, and then asked them or presented them these same kinds of vignettes, I expect that that would have a drastic effect on, for instance, people's kinds of judgments about other people's cases, not just their own status, but also other people's disease as well. So I think that in the case you described, I think I want to say that it looks inconsistent in the sense that what I said earlier was about people seem to be resistant, as it were, to kind of wanting to make descriptions of being unhealthy or having a certain kind of disease status. But I suspect that if in fact we were to actually look at these results in a sense where we had that kind of information about what their health history was like, what their, whether they had any kind of active health conditions or managed health conditions or not, and see whether that had an effect on people's kind of judgment cases, I suspect it would have a drastic effect. At present, I wouldn't be able to tell you what that would be, but I suspect that people may be much more likely to make certain kinds of descriptions of those kinds of cases. But I wouldn't be able to say much more at this time.
I suppose when looking at the social determinants of health, there's always a social gradient in looking at the disease. But in your study or findings, do you found there's a difference in opinions between different socioeconomic position, between different education level, income, or yeah?
So lately we found that age mattered, but there isn't a real consistent pattern that we find in the data. So again, we need to look at this more systematically.
Yeah, so there have been some things. So we don't take an extensive background regarding people's kind of health status or regarding their demographics. We do take some standard information, so for instance, gender, age, political ideology, and ethnicity. And in some sense, the kinds of things that kind of play out are the kinds of things you might expect. So for instance, when we look at judgments regarding kind of responsibility regarding kind of condition, having a particular kind of condition, people that lie towards the more kind of conservative end of the spectrum think that people are much, much more responsible for the conditions they in fact have, versus those that tend towards away from that, tend to view it as in the other direction. There are some things, so for instance, in the context of obesity, for instance, we've found that males are much more likely to think that you're responsible for being obese when compared to women and gender diverse people. And also with respect to one thing we were looking at, Jacob Stinger, was low sexual desire, whether that was kind of gendered or not, in the sense that whether you had low or high sexual desire, whether that was something that, whether gender would have an effect and whether that's considered to be a medical problem or not. And actually there we found no evidence of any effect of the gender of the respondents and no effect of the gender of the patient being described. And so gender had no effect, at least when we looked at it in the context of low sexual desire. The one thing I wanted to say about that particular case, though, is in some sense, one thing that might be interesting about this case where gendered factor might come up is that the relationship that was described in that particular vignette was one where people were in a kind of a loving, committed, and where people kind of, they understood each other. So in some sense, at least in the kind of vignette we described, the person with low sexual desire was partnered off with someone that obviously didn't mind it. And the person with high sexual desire, irrespective, was partnered off with someone that didn't mind it. But I suspect that if you actually made it the case where the partner minded the person with the judged to be atypical sexual desire, and where you made the person who minded it, whether they were male or man or woman, then you might see the kind of gender dynamic to come back. But at least the first pass, it didn't come out there. But we have funding currently to look at socioeconomic status and inequality, so hopefully we'll have a much more kind of richer information about the actual participant backgrounds and see what effect that has.
I have a question. Do you think people's opinion about health is changed? In other words, do you think that people's opinion about health 100 years ago and the present is different or same?
Yes. So I think this is not something that our data obviously reveals much about. But if you look at it historically, I think the change is evident. There has been a kind of a semantic shift in the conditions we now refer to as healthy as compared to 100 years ago. A good place to do research on this stuff is the literature on medicalization, showing how many conditions have come into the purview of medicine since 100 years ago, and how many conditions have left kind of the area of competence of medicine. So just a very a terrible case that until 82, homosexuality was listed as a mental disorder. So those conditions go in and out. Alcoholism came in, PTSD came in as a medical condition. So for me, that means that our concepts are changing. What we call health and what we call disorder, and maybe there is a historical tendency of these two concepts kind of drifting more and more apart. But again, this would require serious historical inquiry into what happens after the Second World War, what happens after these big national health insurance systems come online, right? I think that has an effect on the conditions that we now think of as diseases or disorders too. So it's really difficult to say. I think there is a change, but that's not something that our studies kind of that look at the synchronic picture, look at the picture now, can tell us something about.
How far do you think, given the very different nature of the two and also what I believe very different progress of research on the two, how far is it accurate to combine mental health and physical health as one in your research?
So we wondered about that issue too, and one thing that is taken for granted in the literature, in the philosophical literature, also in the medical literature, that whatever goes for disease, or however we define disease, that's going to be the same way we're going to define a mental disorder too, right? So illness and sickness we forget for the moment because those are slightly different, but there's not going to be a real kind of difference in terms of definition between a disease and a disorder, and we're not entirely sure whether that aligns with people's concepts, with lay judgments. But again, that's not something we have really looked into. But the assumption is in the literature, at least not systematically, the assumption in the literature is that there is no real difference between the two. So when people in the field define disease in one way, they always say, well, this goes for mental disorders too.
I think one way they do come apart, or that I've tried to make them come apart because I think it comes apart in an interesting way, is really when you consider about what the patient themselves thinks about the condition they've been described with. So, and there's something about the mental health case which is very, very different than the physical health case. And that's because in some sense, it seems like if the patient, at least in the mental health case, doesn't mind the fact, for instance, they're anxious, then that might count against it much more than it being considered a kind of a disease or disorder than the kind of physical health case. But at the same time, there are various kinds of cases where when the person gives the evaluation of the condition, we're not sure. Sometimes that's taken to be further evidence that they in fact have a certain kind of disorder. So a classic case of this might be something like, think of like a willing addict, someone who's, for instance, is addicted to something and doesn't mind the fact that they have a certain kind of addiction. So some people have thought that this is a kind of an incoherent kind of case. Why? Because the fact that they desire this particular kind of addictive desire is something that's kind of incoherent in some kind of way. Whereas other people are like, no, that makes perfect sense. Of course you could be addicted to something and in fact desire the fact that you have this kind of addiction. In which case, if patient evaluation matters in these particular cases, then we might want to say that this particular person doesn't have a particular kind of condition. But it seems like if something like patient evaluation comes into play, it seems to play a much different role. If it's important, then it seems to play a much different role in the kind of mental health case than it does in the physical health case. And we see some evidence of that. But in some sense, I think whether it has an effect on the mental health case, it's going to be a case-by-case basis. There are going to be certain conditions for which, take the ADHD case, for instance. I looked at the data recently. People that don't mind the fact they have ADHD, no one thinks there's anything wrong with them. But of course, if the person with ADHD thinks that they don't like the fact that they have this kind of condition, because it prevents them from doing the kinds of things they might want to do otherwise, then in that particular case, then people start to think that person has a condition. Whereas when we compare it to a physical health case, it doesn't matter whether the person thinks, for instance, that, I've got a bit of heart failure, I don't mind it. Everyone's like, of course, no, that doesn't matter. You've got a problem, bro. And so if insofar as patient evaluation is important then, it does look it's going to come out very, very different between the mental health cases. But we're still exploring that in the future.
How far is health and disease in your concept, in your position, totally nebulous, in the sense that it's a bit like how Wittgenstein described families, and that there are various sufficient but not necessary conditions, or various necessary but not sufficient conditions. Like, how far is health the same as what Wittgenstein would describe that?
Yeah, thank you very much. So I think that picture is correct. There are no necessary and sufficient conditions for health. There's not. I mean, we tried this for 50 years, this game, right? And every time somebody comes up with an account with necessary and sufficient conditions, then people start generating counterexamples, and it's just not working. Also, we know from work of psychologists that most concepts, but there are very few concepts actually that have necessary and sufficient conditions. So most concepts are like that, prototype concepts. They have different properties clustered together, that they're not going to have necessary and sufficient conditions. And I think that this aligns really well with this type of approach where we go from judgments to the content of concepts, and getting closer to some core that we can predict will have certain effects on judgments, but not really getting to necessary and sufficient conditions.
I mean, another thing that might be going on here is that really there's just a plurality of concepts. We just got this one term health, and there are many kind of health concepts. Some of them play really good roles, others maybe play less good roles. And sometimes we get kind of hopelessly confused because, of course, we use this one term. And when I'm using it, I'm trying to maximize maybe my own kind of well-being in some sense. When the kind of public health official is using it, they're trying to not pay any particular attention to my own, but they kind of maximize other kind of groups. And maybe the thing to do in these kind of cases is that, look, we've got maybe 7 different concepts. We want to scrap 4 of them, keep 3 of them. Maybe one of them deserves the kind of label health, and to try disambiguate things, we'll call it this one. And we'll come up with new terms for these other 2 ones and see how we go. Whether that's right or not, I wouldn't be able to say. I mean, just given the kind of consistent responding, I think it's probably much closer to the kind of prototype view that was kind of being described. But it's another alternative if you want to hold on to that. There might be these kind of necessary sufficient conditions lurking. It's just that there are actually maybe several different concepts which have slightly different conditions associated with them, but we just happen to have the one term that picks out the family of them.
I mean, maybe just adding to that, that's actually a question we talk about quite a bit. So how would you find out whether there's just one concept that is fairly vague, right? Or there are several concepts, several prototypes or sub-prototypes in it. That's just a very challenging theoretical question too, that we don't really know how to deal with it. At least I don't. Maybe you have some new thoughts on this.
No, I mean, I think that the response there would be, it's not the kind of thing that I think would be necessarily settled by looking at empirical data. I mean, in some sense, there might be certain kinds of, I mean, put it simply, I don't think a theory of concept should be settled by experimental philosophy. Like, I don't think that's the right way around. In some sense, the kinds of judgments that are kind of issued or given to us by experimental philosophy are kind of neutral with respect to what approach you might take. Like, of course, it might fit more nicely with certain views than others, but I don't necessarily take them to be rule out certain kinds of accounts or not. Like, I could imagine someone looking at this data, we would think that this is perfectly compatible with some kind of neo-descriptive view about concepts. And of course, you could be like our collaborator, Edward Macheray, and think that actually there are just patterns of judgments. And in some sense, if there's anything to be called a concept, it just supervenes on whatever kind of pattern of judgment we in fact kind of observe. And so they go from a real minimal view to a very, very kind of thick view. And in some sense, both are going to look at the data and be able to tell a story about how that particular thing, how it works for them. But of course, what this data is going to tell you at least is, well, what are the kinds of factors that are likely to feature, or what are the kinds of factors, whether it be as part of the content of a concept, or just in terms of influencing the judgments that we in fact observe.
Thank you very much. That was all terrifically helpful. I'm slightly curious about your first finding, this baseline idea that people are really resistant to judge people to have a disease. And I was just curious about whether, well, how do you think that might have been inflected if it was a first-person narrative rather than a descriptive vignette? So I have trouble deliberating, it's affecting my family, and so forth.
Yeah, I mean, great question. So yeah, this first-person, third-person distinction is likely to play a big role. It's interesting, I'm not sure exactly what I would predict, though. I mean, given the same dysfunction. So, for instance, I could imagine, for instance, so take, for example, a paradigmatic case in the theoretical literature, but one which maybe sounds strange to many other people, something like color blindness. Like, if my friend, for instance, if I find out, for instance, that that person over there is colorblind, and so can't perform certain kinds of tasks, it's unlikely to affect my health or disease judgments. But of course, if I myself am colorblind, I'm probably going to judge much the same. Or at least, in the sense, it's not clear I would. So there's going to be something further going on here, but I'm not quite sure what it might be. One other distinction I've been interested in is this kind of abstract concrete distinction between these kinds of cases. So one idea I've been toying with is all the cases we've described are quite concrete. They describe someone who has relationships with friends and family, that has a job, that is doing various kinds of things. They have this condition, and it has an effect on their life, but by and large, they're able to they look kind of functional and kind of ordinary matters. But what if we stripped away all the kind of concrete details of these cases and imagine you're presiding over the latest issue of the DSM or some kind of catalogue of kind of diseases, and someone describes to you, look, there is case X. Person X has sporadic anxiety that interferes with their ordinary function or their ordinary day-to-day activities. 4 doctors over here say it's a disease. 4 doctors over here say it's not. You're casting the deciding vote. And once you strip away all these kind of concrete details about, the kind of relationships that these people hold, the kinds of values that they make of it, the things they like, the things they dislike. So all these kind of concrete details that kind of make it. Then would you start to see a much more kind of people much more readily to make these kind of disease and disorder judgments? And I suspect you would. So I think the first person, third person definitely matters, and probably matters more for the mental health cases than the physical health cases. And I think for both, I think the kind of abstract concrete distinction is probably going to make a drastic difference across both, where once you kind of strip away all the kind of personal details and are left with just a description of a certain kind of phenotype that has certain kind of maybe reliable consequences, but it doesn't really matter, certain kinds of consequences, then you'll see the kind of the readiness you would expect to see to assign certain kinds of disease judgments to people. But yeah, I definitely look at the first person, third person as well.
Yeah, next to the abstract and concrete distinction. That's on the list too. Thank you.
Well, while you're waiting to formulate the next question, let me try one. I mean, I want to go back to this thing about family resemblances. So the notion of disease has been around for a long time. So, and there have been all sorts of professions and interests and theories inputting into the way we use that word. So one might predict that our usage of the word is a bit of a mess. So I was surprised by your answer on the family resemblances thing, because it looks as if what your methodology is designed to do is to seek patterns. So can you say a little bit about why your methodology, your apparently pattern-seeking methodology, how that matches up with your rather pessimistic expectations that actually there is a pattern here, right? You say we might have 7 different concepts, maybe we need to discard some and favor others, perhaps it is all a bit of a mess. Say something about that.
Yeah, thank you very much. So even if let's say even if these concepts were held together by relationships of family resemblance, we would expect to see patterns, right? Just as if you imagine this large picture of a big family, you will see stronger resemblances between closer family members than between others on the sides of the picture, right? So you could say there are those types of patterns in family resemblances too. So we are trying to figure out, well, which parts of this picture are closer to each other, and how do we figure that out? Well, by trying to manipulate certain factors that we attach to health and disease, right? So I think this pattern-seeking method, as you said, also fits the family resemblance picture, at least roughly.
Okay, and just to follow up quickly, I mean, do you think that where you find the clustering of usage, where you find the patterns in the picture, will lead you to an answer to the question, is naturalism true, or is hybridism true, or is the evaluative view true? Or do you think that your methodology shows that they're somehow bad questions because the clustering isn't going to line up behind one or another of these theories?
Right. So that's also a very good question, and something we should also think more about. So it's unlikely that we can say, well, naturalism is just going to be false, because that's not the patterns of judgments are much more complicated than that. So there are certain parts of it, certain aspects of it that are going to be true, like we found with dysfunction. But then dysfunction is going to play this specific role that we are just now trying to know more about, right? So I think what we lastly are trying to do, but this is in the very beginning of this project, is to find out just how complicated the picture is, and just how many more possibilities there are between naturalism, normativism, hybridism, positivism, negativism, right? So I imagine this is a big plot, and right, we were trying to find positions between the positions right now.
Thank you.
Just on the original question, I mean, I suspect also that, I could even have an even more pessimistic view going into it, and I'd still want to do the kind of maybe the experimental X5 thing was, like, we could imagine, for instance, that there is in fact no kind of real kind of lay concept of kind of how for disease. There is just these kind of really strongly held platitudes for various kinds of cases, and beyond that, there's nothing else. And in some sense, you should still something like that would still come out in this kind of project, in the sense like once you tap the kind of paradigmatic kind of cases that people have these kind of robust kind of platitudes towards, you should see some kind of strong kind of alignment and judgment of those cases. And perhaps for all the other kinds of cases, you know, when you try and manipulate things around the fringes and look at these kind of border cases to see whether these factors are in fact having the various kinds of influences these theories would predict, you get a bit of a mess, which in some sense, at least some of the earlier findings, are like that. Like, for instance, there's a kind of a robust finding both for medical students and lay people towards the hold fixed for a person's disease, can they be healthy? So there's a kind of a platitude here that, yeah, of course you can have a disease and be healthy. Even if I judge you have a disease, I judge you can be healthy. But once you start maybe kind of trying to finesse things a bit away from these kind of cases where people have these kind of robust platitudes towards, then you start to get the kind of, well, maybe there's just a kind of a default erring, like, unless I have more details, like I'm just going to default to you're healthy and you do not have a disease, unless I have really good reason otherwise to judge otherwise. And so there might be a certain kind of defaulting here, which is maybe the kind of, this comes to your second point about how it might push in between different kinds of theories. So, yeah, I mean, one other way of kind of reading the kind of the reluctance might just be, well, it's not a reluctance because it's kind of there's kind of an evaluative concept kind of backing the reluctance. Maybe, I mean, I think I have a similar view about maybe various kinds of responsibility or kind of free will judgments. It's kind of a default to, you know, health, being healthy, not having disease, being free and responsible. And there are various kinds of defeaters that can kind of be presented towards that. And maybe we just haven't kind of hit the relevant kind of defeaters or something like that. So, so in some sense, the kind of analysis does seek patterns, but of course the kinds of patterns we observe could be indicative of even very much weaker positions, like we just find cases where there are robust platitudes and the rest turns out to be kind of chaos. And of course, when it comes to how you then adjudicate what these results do, I wouldn't want to think that X-Fi is necessarily in the business of kind of settling, it doesn't have to kind of settle philosophical debates. But insofar as you might think various kinds of debates rest or make various kinds of appeals to various kinds of lay judgments, it seems like an open empirical question. But of course, if it turns out that I'm a naturalist about these matters, and it turns out that the kind of lay judgments don't align with that, I mean, I can just cast that aside. I don't have to be wed, as it were, to the fact that the lay judgments don't align with my particular account. I might think we have good reasons for, even if this is in fact not the correct account, is the account we ought to adopt. And I might point out that, look, there are good reasons that maybe it's the kind of account that people could come to adopt upon relevant reflection or upon being shown, you know, look at the good reasons for thinking about this particular thing in this particular kind of way. And so maybe, quite apart from kind of settling kind of these kind of descriptive debates about what, as a matter of fact, is our concept currently, you might think these kinds of patterns of judgments, insofar as they show the kinds of things that kind of move or influence people's judgments, it might also point to the kind of concept, if you wanted to say engineer a concept of health and disease, what are the kinds of concepts that people might, upon reflection, come to actually really think of as going, yeah, that's what it is, or I'm quite happy to think of that as it is. And what kinds of projects maybe are giving perfectly good accounts of something. And they might be good accounts to take on board, but might be better to adopt different kind of terminology and maybe just become eliminativist about various kinds of considerations about health and disease.
Actually, I have two questions. Firstly, do you think the change of people's idea about health affect the outcome of your experimental research? Because actually, during the experimental research, you ask people to express their idea and opinion about the stories. So do you think the change of people's idea affect the outcome? And secondly, do you think exploring and study of the nature of health and disease plays an important role in our daily life? Because as mentioned by Wittgenstein, even you don't know the meaning of game, you can still be a great player in game. Yeah, so that's my two questions.
Oh yeah, I think well, we can check it, but yeah, I'm fairly sure that would be the case. I mean, remember just 100 years ago, when you, I mean, that's how I imagine it was, at least infectious diseases came up to people's mind when you said disease, right? And infectious diseases, this was before penicillin, so infectious diseases were lethal, at least potentially lethal, right? Whereas our kind of the first thing that comes to my mind if you say disease today is our chronic diseases such as cancer and cardiovascular conditions, right? So those are really two different worlds already. So I assume that people's reactions to these cases would be different. Maybe we could do these studies in 100 years, and then I'll be able to tell you. Now, just a second question.
Do you think the study of the nature of health and disease plays an important role in our daily life?
Does the study of our concepts of health and disease play an important role in our daily lives? And then the idea was that you can be an expert player without being able to define what a game is.
Well, that's a good question. I think we are experts in the way we deploy concepts. I think we were not lay people, and to some extent philosophers working on this issue too, are not experts in articulating the concept, in trying to define it. And that's kind of the assumption behind the methodology that we use. So we ask people to make these intuitive judgments, and on the basis of the patterns that these then reveal, we can make inferences about the contents of the concept without having to ask them to define them. So they are, in a sense, they are experts, but not experts in articulating them, the concepts, and not experts in trying to define them. Right? I think we are very much all experts in using those concepts.
I just wanted to get your perspective on whether you see some sort of correlation between the political system of countries and the perspective or the dominant perspective on health. For instance, more liberal countries might be more naturalistic or normativistic than others. I'm saying that especially with the sort of drive or with the advent of precision medicine being driven by pharmaceutical companies and examples of like that.
So the only place we've seen it come up so far is just in relation to the kind of responsibility over one's health. We haven't seen it come up in particularly the other kinds of judgments, but when it comes to whether or not someone is unlucky to have a particular kind of condition, whether the person is responsible for the condition, whether the person is blameworthy for the condition they have, then we see the kind of political ideology start to come into play. And namely, it seems to cluster along all these kinds of judgments that you might associate with kind of responsibilities. So not being luck-based, being blameworthy, being responsible, tend to be heavily associated with tending towards being more and more conservative views. And moderate views. I should point out that moderate to conservative are the same. There's no difference there. As you move more and more to kind of liberal, then things like you're much more unlucky to have various kinds of conditions. You're much less likely to be blameworthy for having a particular kind of condition. And you're much more likely to be judged to be not responsible for the condition you have. But that's the only place we've seen that particular kind of fact come up so far. Has it come up?
No, and definitely not in terms of political systems, because our samples are from Western democratic countries, the United States and Scandinavia. So that would be a really nice comparison to make.
Scandinavia varies a bit from the US political system anyway, doesn't it?
Yes, but we still like to think of both of them as democratic states, right? So I thought you meant something like authoritarian states or theocracies, or right?
I mean, interestingly, just in relation to that kind of comparison, because the predominant Scandinavian comparison we have is the medical students in the medical department there. And generally speaking, there is no difference between the people that we get from somebody from the US and the people that were sampled from the medical school Scandinavian people, and also piloting this back in kind of Australia and New Zealand as well. So there hasn't been any kind of differences, at least between those different countries, but of course they're homogeneous, at least in some respects, which means you probably wouldn't predict to see various kinds of differences there either.
Good, thank you. And that brings us to time. So let's thank our speakers very much once again.